Title of the talk is Therapeutic Illusion, but really the surgical decision-making, especially in spine surgery, has always been a topic that interests me. And this is partly because there's so much variability in practice. So there's some spine literature in this talk, but I'll start kind of with a review of some concepts from psychology. So the therapeutic illusion is defined as the unjustified enthusiasm for treatment on both the part of the patient and the doctor. And this is a definition that comes from editorial in New England Journal of Medicine in 2016. But it's actually a borrowed concept from an older idea in psychology known as the illusion of control. Illusion of control is a concept that comes from research into human identification of causality, meaning like the linking of cause and effect. So, for example, some causes are easy to identify. If you flip a switch and a light comes on, that's very straightforward to make that connection. If you come home and your spouse is upset with you, that can be harder. Is it because something you said yesterday or last week or whatever? So the less immediate the cause is perceived by the effect, the harder it is for us to understand the relationship. However, as humans, that's really something we're hardwired to do. We use heuristics, or what are called rules of thumb, really, to make inferences and try to predict the future. So the heading I have up here is from a psychology experiment from the 60s that undergraduates were made to do. It was done at Duke. So basically 50 undergrads were put in front of a board with 2 buttons and a flashing light. And they were told that you need to figure out how to press this button in a way that, or sequence that makes the lights light up. And they were given 60 trials to do this. The researchers found a couple of interesting things. First is that almost every student at the end of the trial thought they had succeeded in figuring out the pattern. Most students thought they actually learned very quickly and didn't need all 60 trials. Even more interestingly, most thought that they were able to explain to the next student in line actually what the sequence was. So they were able to teach the next student how to press the buttons to make the light up. But what they didn't realize, what you probably guessed by now, is that the lights were really randomly flashing on and off. The buttons weren't connected to anything. And so not only were the students sure that they had found a solution, they're willing to spend a lot of time teaching other people about it. And this is really where the illusion of control comes from. We can control the world to some degree. However, there's this innate human quality that's wired into us. We often think we can exert much more control than we're actually able to. Sports, are filled with examples of ritualistic behavior. This is the Cubs, obviously known for a long drought. They had 108 years before they were finally able to get a World Series win. Jason Giambi was known to wear a gold bong to get out of a hitting slump. Wade Boggs ate fried chicken before every game. There are really countless examples in sports of this kind of thinking. Gambling, obviously, another situation where this applies. There are all these sayings: don't wear red, going to the casino through the back door, whatever. So sports and gambling are kind of less serious examples, but what about medicine? So, this is a picture of Bethlehem Hospital, or Bedlam. It's a famous, notorious hospital for the mentally ill in London. And they were really infamous for all sorts of torturous treatments of insane patients. One of the things they did was what's called rotational therapy. And this would be if a patient came in mentally ill, one of the things they tried to do was hang them from the ceiling from a chair and rotate them, sometimes very quickly. Obviously, most patients vomited and experienced vertigo, but these were really seen as healthy reactions with the potential for healing for these patients. More obvious examples: trephining, probably the oldest neurosurgical procedure, evidence dating back to the Mesolithic period for this. Bloodletting and leeching, also thought to once have multiple therapeutic indications. More recently, insulin coma for schizophrenia. This is a treatment from the 50s that obviously has fallen out of favor. Arthroscopic knee surgery for osteoarthritis. Antibiotics for sinusitis. Universal screening for breast cancer, recently controversial, especially between radiologists and oncologists. And then feeding tubes and advanced dementia. So to highlight one of these as a surgical example, this is a paper from New England Journal of Medicine. It was a randomized controlled trial for arthroscopic knee surgery for osteoarthritis. It was a widely performed surgery for treatment of knee pain. This is really thought to be very efficacious. This is a randomized controlled trial from 2002. 180 patients found to be no benefit for pain relief. And this finding was so contrary to the current practice that many didn't believe it. So it was repeated again in 2008 with 178 patients, and it basically corroborated the previous study. So, 2008, a long way from trephining in the Mesolithic period, but it's still, an example of doing questionably efficacious surgery. Well, why is this? One possible explanation is this concept of regression to the mean. If you treat a pain, and pain obviously waxes and wanes. If a patient seeks treatment at its maximum, at some point it's going to come back down to the more average, and this might explain some of it. Closer to home, we can talk about vertebroplasty for osteoporotic fractures. This has become a recently controversial procedure. Initial studies comparing vertebroplasty to medical therapy showed actually a pretty good benefit for vertebroplasty. And it was really thought to be unequivocally beneficial, and the debate sort of shifted to whether kyphoplasty was better than vertebroplasty or vice versa, and not whether it was actually worth doing at all. However, in 2009, 2 studies came out which really called this into question, and both of these were randomized controlled trials. Both had a sham surgery arm rather than a medical control, meaning that the controls actually had a procedure done to them where local anesthetic was infiltrated into the periosteum. And they also went so far as to even open up the cement on the back tables, so the patients were able to smell that. And while these trials weren't perfect, and some people criticize, for instance, the volume of cement injected, they certainly weren't the slam dunks that I think they were expected to be. Neither really showed a statistically significant improvement in pain, and really sort of called this procedure into question. So this is from a commentary that was written relatively soon after those papers were published from Doug Orr, who's an orthopedic spine surgeon at Cleveland. He says, "It's very difficult for me to look at my own experience with vertebral augmentation and say that on the basis of these trials, I'm no longer going to offer it to my patients. I understand on an intellectual level that these trials call the efficacy of the procedure into question, but on a visceral level, I can't rationalize it." So where does this come from? If you look at the psychology literature, there are actually a lot of reasons humans tend to think this way, but I sort of wanted to highlight 3 of them. One is that we imagine patterns that don't exist. It's easy for us to see patterns of events around us as a result of something that we've done, when in fact, there's really no relationship there. The brain's so predisposed to pick up on patterns that it can create them even when they're not present. 2 is we see what we want to see. So, specifically, we look harder for and latch on to evidence of benefit, and so we often find it. 3rd is that we choose goals selectively. Even if we start a treatment for reason X, we see Y and Z changes, so we conclude that the treatment seems to be working. And we can look at each of these in a little bit more detail. So first, we imagine patterns that don't exist. One example is the hot streak in sports, or example of players so-called heating up. This is a data from a 1985 paper from Cornell that looked at this concept. They looked at 9 players from the 76ers from the 80 and 81 season and looked at the conditional probabilities of a player hitting a shot, based on the results of the previous shot. That's what this table is in the upper right-hand corner here. And they really found no evidence for shot-dependent outcomes. And so they're thinking, well, how do we control this even more? Well, free throws are even a more controlled example of this. There's no defender or anything like this. So if there really is shot-dependent outcome, then we should look at that. And even looking at 2 years of free throw shooting from the Celtics from the 81 and 82 season, there's really found to be no evidence of streak shooting either. So, this is another example of things that are sort of commonly taken for granted, but if you look deeply, the relationship really isn't there. So we see what we want to see. This is a quote from Francis Bacon, considered the father of empiricism, saying the human understanding, when it's once adopted an opinion, draws everything else to support and agree with it. And even if there's a greater number of examples on the other side, we either neglect or basically denigrate them. And this is another example of confirmation bias. And then last piece of psychology literature. This is work from a German psychologist, basically looking at how we handle increasingly complex situations. He was interested in how people fail. So the way he did this was run large computer simulations and ask people to manage these very complex scenarios, like, for instance, running a game park in Africa, or made them manager of a large city. He didn't really care if people failed or succeeded, but he was sort of interested in the decision making. And eventually these processes would get so complex that they couldn't even be managed by one person. So it was basically designed for people to fail. And he looked at the way people failed, and basically everyone sort of fails in the same way. The more complex the problem gets, the more we have a tendency to focus on, smaller and smaller aspect. So, sort of one of the examples he gives is a man who's in charge of running a small city. And he chose to focus on the schools and did a good job at decreasing truancy rates and hiring good teachers, but the city's becoming bankrupt at the same time, and they're having flooding problems, but the schools are running well, even though the town itself is kind of getting ran into the ground. So, when we encounter a large complex problem, we tend to focus on solving a small one that we can control. And this is a concept known as goal generation. So how do we combat this therapeutic illusion? One is to use countervailing conscious heuristics, basically meaning if we're using an unconscious rule of thumb, we have to stop and think about it and try to, think out loud, basically. The second is that before concluding that a treatment is effective, look for other explanations. Is it an example of regression to the mean? It's a chronic pain issue that waxes and wanes. And the third is if you see evidence of success, look for evidence of failure. So, those are sort of more nebulous concepts, but more concretely, comparative effectiveness research has really been a big driver in healthcare decision-making over the past decade. And this has relied heavily on randomized controlled trials. And randomized controlled trials have been seen as basically the gold standard because they have a very high internal validity, meaning that the randomization process basically eliminates internal confounding factors that would otherwise be present in the study. However, in neurosurgery, especially, there are some problems with randomized controlled trials. One of them is that they're infrequent. They're published at about a rate of 5 per year. They have a very low external validity. And these are because basically due to real world variation in patient mix, surgical skill, nursing skill, et cetera, it's hard to generalize these to daily practice. They may fail to be relevant as new technologies emerge. They're difficult to build and maintain. They're very expensive. And oftentimes the lack of clinical equipoise can make randomization in surgical patients, neither ethical nor practical. So is there a role for registries, and can this help basically solve some of these problems? One of the advantages of registries is that they have a very high external validity. And this is because they capture a large sample of the population. They're very cost efficient when compared with other methods of evidence development. And they're easily scaled. The trade-off with registries, however, is they have a lower internal validity. You can have, basically confounding factors from unobserved bias. So one current debate in neurosurgery is the role of fusion in patients with grade 1 spondylolisthesis. So in 2016, there were a couple of competing articles published in New England Journal of Medicine. One was SLIP-1, the other was a study from Scandinavian countries looking at the role of fusion. SLIP-2 is sort of building on these. And basically the goal is to determine the comparative effectiveness of decompression alone versus decompression and fusion for patients with, a very specific degenerative grade 1 spondylolisthesis, and they have to have symptomatic lumbar stenosis in addition to that. The SLIP-2 study trial is organized kind of interestingly. Basically the patients randomized to either what's called usual treatment by the treating surgeon, which basically the surgeon sees them, decides what treatment they get, and they get it. Or if they're randomized to the database arm, basically the patient's images and a small vignette are uploaded to a database, and then these are reviewed by a panel of experts. After that happens, then the surgeon and the patient review the expert panel findings together and then make a decision. So they're not really randomized to a treatment per se, but they're randomized to, potential recommendations from a group of surgeons. The SLIP-2 expected to wrap up later this year, but this is from some preliminary data that collected with Dr. Resnick and Dr. Gogawala. Kind of some interesting findings. If you look at table 1, on average for grade 1 spondylolisthesis, the fusion was recommended about 58.5% of the time. And the most common single recommendation was for a posterior instrumentation with interbody fusion. And this was recommended about 40% of the time. The lowest recommendation was for decompression with non-instrumented fusion. Interestingly, though, 11% of patients who were entered in the study and scheduled for surgery received at least one recommendation for no surgery from a panel member. And perfect agreement where all the reviewers were agreeing either on the need or lack of need for fusion was only seen in about 20% of patients. So there's a wide, basically variability of thoughts on how to treat this. This is sort of another way to look at it. Basically, this is a heat map which demonstrates the inter and intra-observer reliability. Each row is a single surgeon, each column is a patient. The darker the color, basically the more aggressive, quote unquote, the surgery is. A white square means that the surgeon didn't see them. So a couple interesting things about this. One is the high degree of disagreement among surgeons on the panel regarding the optimal treatment for this. For a given patient, which is a column here, you can see by the color, the dark color is someone who recommended basically instrumented interbody fusion. These light peach colors are a recommendation for no surgery. So amongst these patients, there's a wide variation in what each surgeon from the panel would recommend. But even more interestingly, it's the surgeons, when compared to different patients, also had a wide variation in their recommendations, meaning there's not a surgeon that was always recommending interbody fusion or a surgeon that was always recommending no fusion. There seems to be some sort of nuance from this. And basically, I think it's from, even though this is a very specific definition, grade 1 spondylolisthesis with spinal stenosis, that diagnosis still doesn't capture all of the data of that specific patient. So even amongst this specific diagnosis, there's a very heterogeneous patient population. And so that probably points to the fact that the current classification system we have is basically inadequate to classify these patients. We're still missing data, even with that very specific diagnosis. So in summary, it's kind of hard to know what works. We're hardwired to attribute the cause and effect. We may be inclined to err on the side of believing treatments that we offer are more effective than they actually are. Registries are a potentially cost-effective way to help illuminate some of these effective treatments. And, it still boils down to the fact that, patient heterogeneity or the fact that each patient is unique can be a strong confounding factor for even well-designed surgical outcomes or surgical trials. So that's really what I got. Thank you for your time this morning. I appreciate it.
I will go next. Let me just share my screen. All right, good morning, guys. Thanks, Clay. That was a really interesting talk. I'm going to do a complete 180 and talk about a completely different subject. And this is based off a project that I've worked on for primarily about 3 years during my residency, focusing on biologic approaches for disc regeneration and repair in sheep models. And this was a true collaborative project that we had done with based on the neurosurgery group at Cornell Medical College, as well as a bioengineering group at the Cornell University undergrad up in Ithaca. These are disclosures. So this background's a little bit redundant, obviously, for everyone listening, probably. But degenerative disc disease is the second most common cause of axial, neck, and low back pain in Americans, and accounts for nearly $18 billion of medical care costs in the U.S. annually. It's only second, obviously, to muscle strain. And at the molecular level, early stages of degenerative disc disease involve loss of proteoglycans, which primarily make up the nucleus pulposus, leading to a reduction in hydration of the nucleus pulposus, disorganization of the lamellar collagen fiber network of the annulus, fibrosus. So essentially, the tire surrounding, the threads surrounding the tire become broken down. And obviously with progression, you can get microfissures and tears, which can accumulate within the annulus and then lead to herniation of the disc, and then compressed neural elements, as we're all familiar with. Most recent data indicates that about 300 to 480,000 discectomies are performed annually in America. And one of the biggest concerns about these procedures are recurrent disc herniations. Now, if you look at the literature, they quote it to be anywhere between 4 and 13%. Some would argue that it's probably lower. I can tell you based on what I've seen here so far, it's probably lower. If you look at the older studies, they tend to be higher rates of recurrent herniation, but you can argue that there have been a lot of changes in technical abilities of these procedures, being careful to not create a big annulotomy, being conscious about taking off too much of the facet joint or the pars, which could cause instability and then further exacerbate instability there. And one of the unique things, there's a study by Eugene Carrigy that showed that they were able to actually correlate the size of the annular defect with the rates of recurrent disc herniation. So this has, obviously been something that's been studied for years. And, if you look at mechanical devices, some of the attendings may be familiar with these devices. I've never seen them used, but, things like X-close and barricade. There was a big push for type of mechanical solutions to either repair the annulus or prevent further, disc herniation, material from coming out. The X-close was kind of the suturing device that was used to close up the annular defect. The barricade was a buttress type of device to try to kind of block off the annular defect, and again, to prevent any further type of disc reherniation. However, neither of these devices, and among others, were able to show any significant benefit in long-term clinical trials. To that end, there's been a big push for looking at biologic approaches for annular repair. The lab over at Cornell, by the time I was, started residency here within 1 or 2 years in, they had spent almost a decade between Roger Hartle and a bioengineer up at Cornell, Larry Benasser, looking at different types of biologic approaches for annular repair. They primarily were using a high density collagen gel, and the idea being that they were trying to replicate essentially the annular fibers that were disrupted, and then using something that was similar to that nature to try to plug up the defect. They had done a number of studies, again, prior to me getting involved with these projects, in rat tail models, and were able to show, prior to that, even in vitro studies and then ultimately in vivo studies in rat tails, that there was efficacy in using this high density collagen gel to plug up the defect and then ultimately to mitigate the effects of disc degeneration, over a period of at least 8 to 16 weeks. By the time I got involved with this, we wanted to transition this. We'd kind of done a proof of concept in small mammalian models. And my goal was to try to work on getting this, getting some sort of efficacy within a large mammalian model. This is a concept of, this is an example of the high density collagen gel. And it's something that's very similar to what you do, kind of what you see in the dentist's office. It's a gel that's then mixed with riboflavin. And then once it's exposed to UV light, it cross-links the riboflavin, which stiffens the gel. And it goes from a very kind of gelatinous type of substance to a very stiff one. And, again, I literally think of it as the same thing you get when you get like a bonding procedure at the dentist. They put something in. They actually, the UV gun, that we use for these projects were actually acquired through a dental office. And then it cross-links the gel and stiffens it in place. And so this was kind of the idea. That video was of Stephen Sloan, who was the main bioengineer that I was working with. And that was him mixing the gel with the riboflavin just prior to implantation. So the first shot that we did with this, actually using a sheet model, this is something I worked on with Brenton Pennycook, who's over at WashU now. We were able to take 40 intervertebral discs from 8 different sheet. And this is a kind of study where the type of model that you use is really critical. And we used a drill bit technique to try to make an annular defect. And then from there, we were able to inject the collagen gel, and then we were able to follow these sheep for about 4 months. The one thing I will say is that the surgical technique to get access to the disc, when we did it for this particular project, was a really, again, we're in an area, we learned about minimally invasive surgery. This is a pretty maximally invasive operation. We slice these sheep wide open. We cut right through the psoas muscle and all the paraspinal musculature, which, in retrospect, probably could have contributed to some sort of destabilization and may have biased our results a little bit. And ultimately, what we found was that at the molecular level, we were able to show that the high density collagen gel did mitigate features of disc degeneration. However, on MRI, which is really the gold standard, and if we're trying to take this to the next level and try to use in humans, we didn't see any significant radiographic differences between the discs that were treated with the gel and the ones that were just injured or our controls. So that was something that, again, we saw that maybe if we followed these sheep out a little bit longer, we would have seen changes in the MRI eventually. But it did give us a little bit of pause to think, is our model being done correctly? And then number two, is there any way that we could augment our gel in any way? And again, these were kind of the main findings from that study. The next question we had was whether or not cellular augmentation would actually improve the efficacy of the actual gel, because we were using an acellular formula at first. There's a lot of in vitro and in vivo evidence looking at mesenchymal stem cell augmentation. A lot of the pain guys, it's actually a very controversial topic. The pain guys are injecting, PRP and stem cells into discs to try to mitigate degeneration or to promote regeneration. There's certainly a wealth of literature that shows that mesenchymal stem cells can improve disc health. They do this through a number of mechanisms, through suppression of genes related to degradative enzymes, anti-inflammatory cytokines, and then differentiation into chondroblasts to stimulate regeneration, which is actually their primary use. So we took, based on this evidence, what we decided to do was actually harvest our own mesenchymal stem cells from allogeneic sheep femoral bone marrow, and then seed it onto the high density collagen gel, and then compare it to the acellular formula to see if there was any benefit with adding the cells. This was again, I was able to spearhead this project. It was really a pilot study that was trying to be proof of concept. We made a lot of changes to our model. And again, we're talking about small numbers here. You have to keep in mind the finances that it takes to run a project like this. And so ultimately in the pilot study that I ran, we took 15 discs from 3 sheep. And though we essentially randomized them to different groups, either they were intact, they were injury only. We tried to standardize our injury and try to replicate what's more commonly done in humans by doing a very specific box-shaped annulotomy, plus a very specifically weighted nucleus pulposus discectomy. We had one group that was just injury with the acellular gel, and then another group was with injury in the mesenchymal stem cell seeded high density collagen gel. And we followed these sheep for 6 weeks. Now, among the things that we did that was different, I got to work with different cadaver sheeps. And what we did was, rather than kind of do this blow through everything, cut every single muscle, what we did was use a modification of an approach that a veterinarian group out of Australia had used. And essentially what I was able to do was, I think it's analogous to an OLIF or an ATP, an anterior to psoas approach, where we were able to isolate the psoas, do a little bit of dissection off the transverse processes, which in sheep are about 3 times the size of humans. And then we're able to use, I used, O-vicryls to tent up the psoas muscle at 3 different spots and pull the entire psoas muscle up, which gave me a very clean access corridor to the entire anterolateral aspect of the spine. And by doing this, again, the goal was to try to minimize, again, any type of instability that the sheep may have, which could promote, further degeneration, to try to preserve as much of the soft tissue and musculature as possible. So again, this is kind of just an intraoperative view. This is taken from the belly side of the sheep. They have a very large peritoneum, and similar to humans, once you put them on the side, the peritoneum completely falls forward. And so again, it's a very clean approach. There's minimal blood, bleeding, minimal cautery that's required. This is a closer view of the actual annular defect that we made. And then on the bottom, you can see once it's actually plugged up with our high density collagen gel that's already been exposed to UV light. What I will say, you know, I've seen enough talks of Dr. Wang and Dr. Levy's, and one of the things I love is that they're very honest and upfront about complications and outcomes. And I was a PGY4 when I first started doing these surgeries. I was trying to get my legs under me as an independent surgeon. And I don't have the advantage of looking at the preoperative imaging in these sheep, obviously. And unfortunately, I can tell you on my second case that I did get an iliac injury, and it's, you know, again, I want to be honest about my outcomes. And so, unfortunately, I did have a sheep die on the table, completely exsanguinated out. I hope it's the first and last life that I lose on the table, but that was, you know, again, I want to be honest about my outcomes and complications here. But again, it was a good learning lesson. And again, I was very careful about preserving the vasculature on subsequent cases. You know, moving forward, you know, when we finally sacrificed these sheep and then looked at different outcome metrics, we found that and again, we're talking small numbers, you know, to say anything was statistically significant is an overstatement. But we were able to at least show in this pilot study that the discs that were treated with our mesenchymal stem cell treated gel were able to preserve more integrity of the actual disc based off Furman grading on T2 MRI images. We also used quantitative T2 relaxation time to give us a quantitative assessment of the hydration of the disc. And we're able to show that our, you know, our primary group of interest was closer to the intact group as opposed to the acellular gel and opposed to the group that was just had the injury alone. On microscopic analysis, again, we were able to show that there was, you know, preservation of disc height. There was less disorganization of the actual matrix within the disc, and there were less end plate changes, which again all pointed towards a, you know, a positive result. And ultimately, based on the pilot study, you know, the main thing was to ensure that there was no adverse immunologic reactions, even though, you know, these were allogeneic stem cells that we're using. We were able to, you know, reliably and reproducibly use a safe surgical approach that had minimal disruption of the soft tissue. We did notice that there was mitigation of disc degeneration within our stem cell treated gel group. And then we were able to also show that, again, at the microscopic level as well as the imaging level, that there were advantages to using this gel. Since I've moved on to the lab, you know, the group has continued this, and, you know, we ran into a lot of issues initially with using the stem cell based gel in terms of standardizing the actual number of cells. There were a lot of issues that we had that they were coming out with different numbers of cells, or, you know, it wasn't a reliable process. And furthermore, if we were realistic about taking this through the FDA and getting into humans, we had a consultant that, you know, used to work for the FDA, and I mean, Dr. Levy probably knows this better than anyone in the country, but trying to get a cell augmented therapy through the FDA to use in humans is an exceedingly uphill battle rather than using an acellular formula. So going back to the drawing board, the group, you know, we've gone on to now do another round of experiments. This is again done in eight sheep and 40 intervertebral discs. And the idea here was, well, our previous experiments were just repairing the annulus fibrosus. What if we were to also augment the actual nucleus pulposus itself? And so the idea here was to do the same approach, same injury mechanism, however, to inject hyaluronic acid within the actual heart of the disc, plus then our high density collagen gel to patch up the actual defect. So really, you're putting more air back in the tire, so to speak, and then patching up the hole. And so far, you know, this is a paper that we were able to get published in Science Translational Medicine, able to show a lot of the same features. We're able to show mitigation of disc degeneration at the imaging level based off quantitative T2 imaging. At the molecular level, again, able to show preservation of disc height, less reorganization. We were able, you know, one of the problems that we couldn't get right with my project was to fluorescently label the cells as well. And they were able to do it for this project, which shows that the gel is actually incorporating into the native annulus fibrosus and nucleus pulposus. And then we went a step further. You know, one of the criticisms or critique that I got from my paper was that there was really no biomechanical data to support our findings that showed, you know, does this thing actually spit out when it's under high loads. And we were able to do it for this project. I will tell you, this is a very busy slide, but the punchline is that it was not significant, and there was very minimal changes from a biomechanical perspective using our gel. There are a lot of confounding factors which may have contributed to that, looking at torsional stiffness and torsional angles. But again, that's certainly something that we want to continue to use in all of our projects moving forward. And, the last thing I'll mention is that, I had an engineering group from Cornell doing one of these hackathons who approached me about using, trying to design some sort of device that they could engineer that would help with, a surgical problem. And the fact of the matter is, if we're filleting these sheep open and then having full access to their spine, but in actuality, if this is something we want to take to human studies, we have to be able to do this through a minimally invasive approach. And I train with Roger Hartle, who uses tubes and metrics tubes for everything. I mean, he eats his dinner through a metrics tube probably. And so I told the engineering students that I want to be able to do exactly what we were doing in our open sheet through a minimally invasive approach that I could do through a metrics tubular retractor. And these guys came back within a week with this schematic, and over the course of a year, they were able to come up with a device that has the syringe loaded onto it that can actually, through a rotary mechanism, move the needle out. So imagine you're doing this, you just did a discectomy through a metrics tube. You put this gun in, it has a shaft that's able to accommodate up to an 8-centimeter tube. It has a rotary mechanism that you can use with one hand with your thumb. It expels the syringe. You can push the gel in, and then you pull the trigger, and that activates the UV light that's built in through the separate barrel. And then so, with one motion in about 1 minute, you can actually give the gel and then cross-link it and then pull it out in a very safe way. And over the course of the year, we were actually able to develop a prototype. We've submitted this for patent. It's patent pending right now. And again, we were trying to work in parallel. That's, the idea being that this would be a prepackaged sterile device, something similar to like a Duracell or an Adherus that, comes with a gel that you mix off on the side table, and then it comes with its own delivery mechanism. And so again, while we try to refine the gel, the idea was to try to create something that we could actually use in humans reliably. And so I just want to acknowledge, Roger Hartle and Larry Benasser were my main PIs here. Jonathan Cheatham was our liaison at the Cornell University Veterinary Hospital, which is mind-blowing that they have hospitals that actually function as well as human hospitals that can accommodate the surgeries that we were doing. And that's it. Thank you.
I guess I'm next. Can you guys see my slides?
Yes, I can see your slides. You're ready to go.
All right, perfect. My name is Slav. I'm one of the spine fellows as well. My talk is going to be fairly quick. I'm just going to look at the endoscopic TLIFs and sort of the outcomes from that, or the evidence behind it. Coming into the fellowship, I was very intrigued by the idea of doing endoscopic TLIFs, and my very first case with Dr. Wang certainly didn't disappoint. So let's see. I have no disclosures. So my very first case that I saw was a was a 63-year-old female. She has back pain and left leg pain. She failed non-operative management. This was her pain diagram. Actually had back pain, some numbness in her feet. And this is the pre-op MRI, just grade 1 spondy, multi-level degeneration, pretty significant stenosis at 4-5, as well as foraminal narrowing. And then, we all have seen these sort of serial x-rays from doing the procedure, positioning, and having a great x-ray tech is very important. And the team that Dr. Wang has at the university is amazing, Brenton and Tyrone. And so you take your access needle, find the Camden's triangle, sort of mid-pedicular line, but not past the medial pedicular line. Then you put in your nitinol wire, exchange that to your dilators, then the working channel, rotate the working channel, do your discectomy with different pituitaries. And then once you're happy with the discectomy, you exchange the Joymex working channel to a Optimesh one or Spinology working channel, and then use their instruments to complete the discectomy. And so side the cutting drill, then pituitary, then like a butterfly blade or a side cutting tool, then pituitary is ultimately ending up with wire brushes. And then once you're happy with that, and you look at the wire brushes, there's not a lot of disc coming out. Then you put your balloon in with contrast in it, inflate it to see how much of the end plates you have prepared. And then you still see here a little remnant of the cartilage on the end plate. So you exchange the Optimesh channel back into the Joymex, do more of the disc prep, and then put in your wire brushes again, check it one more time with the balloon. And as long as you're happy with that, then you put your BMP in, you put your Optimesh in, you fill it, and this is the Optimesh filled. And then you do your perk screws with Viper Prime, put your rod in, do the extension maneuver, reduce the patient, sequentially lock the tulips in place or the screws in place to avoid the windshield wiping. And so this is the final product. And the most impressive part, other than the technical aspect of the procedure, was actually like the timing of it. We were in the room at 7:21, and this is just taken from U-chart. And then anesthesia start time was 7:21. They were ready in 7 minutes. Patient position, we did a TLIF block, and then procedure started 20 minutes after that. And we were done a little over an hour after and out of the room in 6 minutes. Compared to most recently, we did an open L5S1 TLIF, and we were in the room at 12:21 after almost a 2-hour kind of turnaround time. And then anesthesia said, the computer said it was ready at 1:11, but at 1:14 they were still putting in an A-line. So we didn't start the procedure until almost an hour and a half after we got to the room. Luckily, towards the end of the case, the anesthesia team changed, and the CRNA that came in was really good. And so he woke the patient up really quickly, and the patient was doing fine. We went to the recovery room. And so, this was 2 months follow-up x-rays on that patient. And then 6 months, we don't have any x-rays, but at 6 months, her left leg pain was gone. Her lower back pain was significantly better. She still had a little bit of numbness in the right foot, but overall she felt better and happy with surgery. And so kind of looking at the outcomes of doing these endoscopic TLIFs. And so there was a paper that was published in last year that did a meta-analysis for single-level endoscopic TLIFs. They reviewed 15 papers, and so 7 were from China, 4 from the US, 2 were from here, 3 from Korea, and 1 from Japan. So a total of 441 patients, and mean kind of follow-up range between 2 and 46 months. 8 were done under general anesthesia, 5 with local, and then 2 with epidural. And then, looking at visual analog scale for leg pain, they saw a reduction, which was statistically significant, of 3.45. And then also VAS for leg pain also improved by 3.36, which also was statistically significant. They didn't really find any difference between doing it on the local or general, but the numbers were low. And then ODI improved as well. Blood loss was 136 mLs, a little less in the local group compared to general group. And then interestingly, length of stay in the hospital, the average was, mean was 4.85 days. But then when you looked at the surgeries that were done on the local, it was 1.4 days compared to general. It was almost 6 days. And OR time was about 150 minutes or 149 minutes. And so there was another meta-analysis looking at the open TLIFs versus MIS TLIFs, and that was published in 2019. And so when you compare that data to the endoscopic one, the leg and the back pain as well as ODI and endoscopic group improved, but they weren't as robust improvement as in the open or MIS TLIF group. But then, blood was estimated blood loss was less, 136 compared to 500 in the open and 200 in the MIS TLIF group. And then length of stay, about 4.8 days versus almost 7 days or comparable to MIS TLIF. OR time was less. But then if you look specifically at what Dr. Wang does here at the university, so his first 100 cases, the ODI was improved, still not as much as if you do an open TLIF or MIS TLIF, but much more than compared to the other 14 studies that this meta-analysis looked at. Blood loss was a fraction of what you would get with MIS or open. And then the most impressive part I thought was length of stay, 1.4 days. I mean, I think a uncomplicated one-level TLIF or one-level lumbar fusion, the hospital gets paid for 3.5, 4 days. And if they stay anything longer, then they essentially are losing money. But if the person leaves in a day and a half or in one next day, then they just saved all that money that could be put into something else. And OR time was about 84 minutes. And so the doing endoscopic TLIFs, at least the way Dr. Wang does them here, does show evidence of helping person. It might not be as a robust improvement as you would get with an open TLIF or MIS TLIF, but that's something that he always consults his patients on when he sees them, that, hey, we're going to do this. This is as minimally invasive as we can get it. It will likely help you, but there's a chance that you might need a little bit more of a direct type of decompression later. And so the papers didn't really look at pseudoarthrosis. I was kind of interested in looking at that. And so these are all the 15 studies that the meta-analysis reviewed. And so follow-up was anywhere from 2 months to 24 months. The 2 months one didn't really look at pseudoarthrosis rate, so that one can be ignored. And then there were 2 other papers that did not report any pseudoarthrosis. And so 3 used OptiMesh, which was 2 of them were from Dr. Wang and another one was from a different surgeon. All of them used Infuse, and then most other implant that was used was a P cage, and most of them were backed up by screws except for one. This one used some sort of an inner body that was made out of titanium and it was expandable and it looked like a Christmas tree. And they reported. So if you ignore the 3 that did not look into pseudoarthrosis, we have about 330 people or cases, 17 pseudoarthrosis. So it was about 5%. And I think Dr. Levy, when I was talking to him, he had mentioned when he was using OptiMesh, he had about 4 to 5% of pseudoarthrosis rate. I wasn't able to find specific papers on looking at fusion rates using OptiMesh online. And so the reason why I think the endoscopic TLIF sort of work is because they rely heavily on indirect decompression. If you're going on the side that has extraforaminal disc herniation, you can remove that. If they have ipsilateral foraminal narrowing, you can certainly decompress that with the reamers or drill or Kersons. But then anything past that, you're relying on indirect decompression. And so there was a nice kind of paper that did a systematic review of indirect decompression after TransPsoas fusions. And so I looked at 42 articles, 2,400 patients, 3,700 levels, and they looked at clinical results as well as radiologic parameters. And so they saw that you have ODI improved, leg and back pain scores improved, and then their failure rate for indirect decompression was about 10%. And then they also saw, like when you look at the radiological parameters, disc height increased by about 67%, foraminal height increased by 21%, foraminal area increased by 37%, and central canal area increased by 29%. So it would be interesting to see if if the same could be kind of measured in the people that do get these endoscopic TLIFs and see what their radiological parameters are at the end in terms of indirect decompression. And so that's the end. I think the endoscopic TLIFs has lots of applications for the correct patient. It certainly has helped. It has limitations, like right now it's being done on a Wilson frame. And so one of the things that you lose with that is lordosis as opposed to doing a fusion on the Jackson table. So if you do more than one level, then you're giving them, you're kind of putting the patient in less lordosis. And so there's also a steep learning curve. I mean, doing the surgery in an hour doesn't happen overnight. I mean, I think at this point, Dr. Wang has done over 200 cases. And so that's a lot of surgeries and lots of learning. And so it might not be applicable to everyone, but it certainly is something that you could strive to achieve. So that's kind of the end of my talk.
That's great, Slava. I'll ask you and Mike. So who is not a good candidate for the surgery?
I think that I've certainly, it's kind of mild to moderate spinal stenosis. On the severe side, it's more of a relative, but I think Dr. Wang I've seen him do kind of more on the severe side of spinal stenosis. And then he also looks at the anatomy of the facet joint as well as the foramen itself on the side that he's going to go on. So you want to be able to put your inner body kind of cross midline, and so you need to be able to access it. And so if the facets are sort of more instead of vertically, they're more horizontally oriented, the access might be more difficult. You might not be able to.
Those are some of the technical nuances, I think. But what I'm asking is, like, who is not a candidate? Like a 90-year-old with severe osteoporosis, and you can't get the indirect decompression by, maybe because you're worried that the balloon will go into the end plates or whatever. That's the question. Who's not a candidate?
I mean, I think that person probably would not be. You're worried that you will break the end plate by over distracting or overfilling the balloon. Or not the balloon, by overfilling the inner body cage. I think, grade 1, grade 2 spinally, so anything higher than that might be a contraindication, bad bone quality. But I think those are kind of the main ones. Dr. Wang?
Yeah, I would agree with that. Thanks, Slava. Those are all great talks. Al and I agree. It's on the one hand, it's great for the really old, frail people. A lot of people we've operated on have had transplants or pulmonary hypertension or whatever. But on the other hand, you're right. You want the best bone quality. Just ironically, last night we did a case where we had a problem with that, with a screw sort of breaking out laterally. Yeah, great questions. It's a work in progress. It really is. And I know some of the residents are doing great work now on doing the endoscopic ALL sectioning. I know Roberto Perez-Roman and Greg Basil are working on that. So we're hoping to beat that lordosis problem that Slava was appropriately talking about not being able to get much more lordosis. Alan, we can give the balance of the time to the Bhatia if you want to do all the introduction and the preliminaries to give the credit of time back.
Oh, that'd be great. I'll get John, Dr. Ragib to step up to the plate then.
Yeah, good morning, everybody. I hope that Jim Drake has joined us this morning, but let me get my presentation up and I'll do a little introduction here.
Hey, John, I'm here.
Morning, Jim. Welcome.
Thank you.
I see you don't have your scarf and your winter coat on, so that's a good sign.
It's spring up here practically.
Right. All right. If you'll just indulge me for a minute, I'm just going to give a little introduction and then I'll turn it over to you. Well, thank you everybody for the time today. Today's a special day on the service, and for all of us, it's an opportunity to remember our colleague Sanjeev Bhatia, who passed in 2018. For those who don't know Sanjeev or didn't have a chance to work with him, came to us at the University of Miami, fully trained after training at one of the foremost neurosurgical centers in India, the All India Institute of Medicine. Sanjeev came to the NIH to do research on temporal lobe anatomy with an interest in epilepsy, spent some time at the Boston VA, and then was induced to come work with Roberto and Jacques as their fellow before deciding that he was going to stay in the States. And he and Rita and the family stayed with us in Miami. Sanjeev was a resident with us. He was so capable when he came that he was sort of rapidly progressed through the program. He was our first fellow in pediatric neurosurgery, then became part of the faculty thereafter. And Sanjeev was one of those people, if you didn't know him, he was, for the most part, relatively mild-mannered and soft-spoken, and had the label by the residents of Uncle Sanjeev because he had the wisdom of an uncle and the ability to mentor us without being overbearing. So we miss him as a friend and colleague. And after he passed, we created this lectureship in his honor, and we can't be more pleased to have Jim Drake with us to honor Sanjeev's memory. Jim is the Surgeon-in-Chief at Sick Children's Hospital in Toronto. He's also the Chief of Perioperative Services, and I'm sure he'll need a drink to tell us all the stories of dealing with itinerant surgeons and other types, but he's managed to stick it out for a couple of years now as Surgeon-in-Chief. He's also the Professor and Chair of Surgery at the University of Toronto. Jim was the fifth in a long line of distinguished surgeons to lead the neurosurgery at sick kids. There's Dr. William Keith, the first pediatric neurosurgeon of note really at sick kids, and then the three H's. And it was really the two Jims that sort of evolved the service. And these are photographs from a paper that Andrew Jay wrote and published in the Journal of Neurosurgery in 2007. The three H's who created arguably the world's busiest pediatric neurosurgery service and the most distinguished evolved with the leadership of the two Jims to make it probably one of the most scientifically based and creative, as well as busiest clinical service in North America, if not the world. So Jim's going to talk to us today about innovation, which is really actually very interesting because I tell people that if I wasn't a neurosurgeon, I'd be an engineer. Because I like to tinker and solve problems with my hands. That's how Jim started his education in engineering. And I think he's applied a great deal of what he's learned at the university to his practice in medicine. Jim's also a great friend, and he was tortured in this effort to try to get from Newport, Rhode Island to Bermuda. As is true for sailors, when things don't go well, we change plans. And instead of sailing to Maine, when the weather got really rough in the Gulf Stream, we headed across the Cape Cod Canal and had a beautiful sail to Maine that ended with this at the top of Acadia National Park and a spectacular view of the ocean. We're really, I can't thank you enough, Jim, for taking time on your busy schedule to do this for us. We're really looking forward to your talk. So I'll turn it over to you.
Thanks very much, John. I'm absolutely delighted to be invited to give this lecture, and so honored that it is in Sanjeev's name. And as you mentioned, we have a long-standing relationship with you, but also a number of your faculty, and it's good to see Al Levy again, who trained here in Toronto many years ago. So it's a lot of close relationships with Miami. So I am going to talk today about an innovation project that I took over about a decade ago now, and it's a little different than what I've been doing before, and I'm hoping you'll find it of some interest. So, I think Al summed up very well in this comment about Sanjeev as a brilliant neurosurgeon and totally dedicated to his patients and teaching, and also very involved in global neurosurgery. And my contact with him was mainly through, I called him up a couple of times about epilepsy cases, and in particular, insular recording and insular resections. And he was an extraordinarily accomplished individual in that regard, and very modest. And, I didn't spend a lot of time with him, but it just so happened that at the IF&E World Congress of Neuroendoscopy in 2017, which is in Cape Town, we ended up spending the day together. And I saw on the list of people here that his wife Rita is, I think, on the call. And I just wanted to comment on his personal attributes, because we spent the whole day together, and I think we really got to know each other much better. And he's kind of a kindred spirit in that we decided in the morning that we'd go and climb Table Mountain, and if no plans whatsoever, you know, we showed up, you know, no water, probably the wrong footwear, and it was blistering hot day. And ultimately we decided just to take the cable car up. So we spent the afternoon doing that, and it was absolutely wonderful. And he was very concerned about my driving, because we were driving on the left side of the highway with a stick shift, which I thought I was pretty okay with, but he was gripping the sides of the, you know, the car with all his strength, and trying to navigate at the same time. And then that evening we went to Llewellyn Padachai's house, and Sanjeev got right to work, and he decided he's a good cook. He's going to make the salad. So he was wonderful, I think, in every way. And I just can't imagine how much you and his family miss him, and what a loss it was for him to pass away so suddenly at such a young age. So I think he's someone that we can all aspire to be more like. And I'm, again, so thrilled to be able to give this lecture. So John alluded to my background, which was in engineering, and where I ended up, as I said, this last decade. And this is kind of where we ended up working. And this is the interface between engineers and surgeons and a large group of other medical professionals. And this is a book we put together several years ago with Waleed Farhat there on the left, and he's a urologist. And there are two of our MD PhD students working on a surgical robot that I'll show you a little bit about later. But this is the kind of, and both these individuals came from an engineering background. So this is the kind of group that we're trying to bring together to see if we can advance the technology, particularly for pediatric neurosurgery, but as I'll show you, also beyond. And the woman there on the left was Amy, and she made this video, if it, okay, about what the duty is all about. And we actually are in the hospital. So we're up in a lab in the hospital. We have an MRI across the street, and this is one of our Dimension test kits. As I said, it's hard science and engineering focus. He's one of our robot controllers, a lot of 3D printing. And this is one of our neurosurgical robot prototypes that I'll show you in a second. And this is some of our 3D printing for skulls. And these are all, so this gentleman came from applied math. And this is a plastic surgery resident who did a PhD, and that's a ventilator for premature infant that was created by a group of the pediatric intensive care unit. And that's the young gentleman who's now in medical school doing a residency in radiology. And this is our focus ultrasound machine. That's a very quick spectrum of what we're involved with. And these are kind of the main areas that we're focused on. So one is developing minimally invasive tools for a variety of surgeries, including neurosurgery. Tools for other applications, and that's actually an endoscopic tool for the GI tract. 3D printing to develop models, which we really started in order to develop robots, and then using focused ultrasound for a variety of applications, including in the brain. And the focused ultrasound machine is actually, when you take it apart, it's actually a robot. And this is the group that we have brought together. So as I said, it's about 2/3 engineers and 1/3 physicians, medical students, postdocs, all working together in our lab and working on projects. Okay. Like this, and this was an auto suturing robot. This is one of the first projects that I kind of inherited, designed to automatically sew structures together, including in this case a synthetic vessel. So this was, I thought, extremely aspirational. And after 5 years, we did have a system that would auto suture about the same speed as a surgeon, but it really didn't seem to be a huge advance in that regard. And getting robots so that they're surgical robots, so they're totally autonomous, something like we envisioned for self-driving cars, I think it's still a ways off. And often it's the simpler systems that actually I think are going to come into application much quicker. And we've also done work with simulation and immersive reality. So this is one of our early prototypes. So this is an MRI compatible robot that was designed to do biopsies. And so in this particular application, we're using it to biopsy bone, but we've also developed a version that would do brain biopsy and actually another one for inserting radioactive needles into the prostate. So it's kind of the area that we're working in, and that we develop a robotic system. So this one is MRI compatible, can work in the MRI while the MRI is taking images, which is difficult to do with the current motors and technology that we have available. But that was a prototype that we're using now, and we're hoping to get that into clinical practice, in fact, for prostate in the very near future. And I guess one of the common themes you'll hear, and you hear this a lot in medical robots, is that people do, preclinical testing, but actually getting devices to humans is actually quite challenging. And this is the, as I said, the MR guided focused ultrasound machine. And this is not a cranial system. This is a body system. This is the Philips system that has a transducer in the table. And we've used it for a large variety of applications that I'll talk to you about. But I think one of the most interesting parts of this is the interest that the clinicians have in this type of technology transfer. And we've tried to set up a system where clinicians from a variety of specialties come with a problem that they want to solve and looking for an engineering solution of one sort or another. And the real advantage of that, from my point of view, is that, when and if we can get this to the patient, then they're the ones who are really going to drive the technology forward. So in a lot of instances, and we've been in that position, we've developed the technology looking for an application, and I think it's a much more difficult and likely to be more unsuccessful than having a system like this. And I'm not going to go through all of these individuals, but they're all from other specialties than neurosurgery. So ear, nose, and throat, general surgery, neonatal intensive care, urology, anesthesia, plastic surgery, and at the bottom are some engineering collaborators. And this is the same in our focused ultrasound program. So these are, again, our core faculty, our postdocs and staff, students, and our faculty that are involved. And if you ask me what is our biggest contribution to date, I think a lot of it would have to do as an education and training center. So there's been a large interest in students from various backgrounds, usually the hard sciences or medicine, coming through. And at the moment, we have a group of about 30. And over the past, we've trained a large number of PhD master students and undergrads, in particular undergrads in engineering and in particular robotics. And we've also tried to get people interested early. So this is a robotics challenge we held with high school students, and they challenge was to build a neurosurgical biopsy robot out of Lego Mindstorm. And then some of these students have come forward and then started to take up a position in the lab in one sort or another. So I think this is a good way to get people interested in this early. And this is, I'm just listing here some of the master's student thesis topics. I'm not going to go through them, but it is a wide range of applications for medical applications for either tools, robotics, or MR-guided procedures. And these are again, the PhD or MD PhD students who have also come through the lab. So as I said, I think we are somewhat unique, and I think we have an advantage by being in the hospital and this mixture of clinical and engineering faculty and students. And we are in the technology transfer area, which is, I think, relatively new for a lot of universities and also in the University of Toronto, but one of high interest. And we do try to have industrial partnerships and have had a few spin-offs and startups over this, but like many, it's a very difficult path to follow. And I've talked about some of the advantages of this. So, as I said, my particular interest has been in endoscopy and robotics, and I think I'm showing what are the limitations that we currently have. And so this is a patient with a small metastatic lesion in the back of the third ventricle with fairly large ventricles themselves. And this is one of the tumors that we can remove surgically at the moment. And so this is coming in through the foramen of Monroe. We're a fairly anterior approach. You can see the tumor here on the side of the ventricle. It's relatively avascular and it's small. And with biopsy forceps, we can remove a piece of it. There's not any bleeding, and then using a NICO device, we can shave it down. But if we did get any significant bleeding, there's not much that you can really do, and you could be there for a long time irrigating. And so what we're trying to develop are systems and tools that could reproduce or situations so that you could do almost the same thing you could with an open procedure. And Mark Suedain, I think, summarizes very well in terms of purely endoscopic removal of brain tumors. What are the shortcomings? And as you see, bipolar forceps was the #1. And so bleeding is the part that really makes this very limiting and where you can quickly lose control. We talked about an ultrasonic aspirator or tissue shaver, and then 3D endoscopy. So this is the sort of thing we ended up working on. And so like many centers, we tried to produce a miniature Da Vinci because that's what has been so widespread throughout the world and has been used hundreds of thousands of operations. But we need 2mm instruments, and you can't really scale a Da Vinci down to that level. And we, as well as a number of others, have tried. And the instruments are either too fragile or they're so small you can't fabricate them. If you can fabricate them, you are very difficult to assemble. And if you can assemble them, they're not very robust. But this is a different concept. This is a concentric tube robot. And these are curved nitinol tubes, and they remember their shape. So they have shape memory. And by rotating them and moving them backwards and forwards, you can actually produce a workspace that looks like this. So this is where the tool comes out of the end of the scope, and then it goes out into an area like this. So this is exactly the kind of workspace we'd be interested in. We're showing one of our designs here with 3 tubes. So 2 working channels and then a suction or aspiration channel here. And they're industrial strength, so they're extremely strong. So those are the kind of things that we think might be the solution for a miniature neurosurgical robot. These are some of the dexterity features that we're interested in. As I said, we want something that can generate significant forces and is reasonably fast and also accurate. And we're designing these systems around specific patients. So this is a patient with a pineal tumor, and this is a simulation of the ventricles. This is a tumor here itself, and this is the type of concentric tube robot that we would need in order to remove this tumor. And this is, again, this is, I think, version number 2. And as you'll see, it's got two working instruments. They're scissors and graspers, and a lot of this design is done on simulators. It's teleoperated, so it's a master-slave system, very much like what the Da Vinci uses. This is the workspace that I talked about, and these are the overlapping workspaces for the 2 tools. It's quite accurate in terms of its precision, and these are validating its performance. And this is what the device looks like on the bench. These are the 2 working tools, and so we're getting to the point where it's actually starting to do things that we're really interested in. And so this is a standard peg transfer that any robotic system is usually tested on. But what we're really interested is trying to do things that we can't do at the moment. And that's picking something up and cutting it. So if you've ever tried to do this with the standard endoscopic instruments, this is really hard. And the instruments are not curved, they're straight, so you can't really see beyond them. And so this is obviously, just a demonstration, but we're going to pick up a piece of thread and cut it. And so those are the kind of things that we're very interested in trying to develop. And this is our 3rd version. This is our current version. And we now have 3 arms. You can see it's getting larger and larger, but it does work inside a 3D printed model of the brain. We've used this in some animal testing. And we actually have a collaboration with a group at Boston Children's to develop a device that we can believe use in humans. The other procedures that we're interested in are minimally invasive hemispherotomy, and this is the same system, same idea, but for a different application. And what I haven't told you is some of the downsides of concentric tubes. So there's 2 of them. One is controlling collisions between the 2 arms. You obviously don't want them hitting one another. And the other is that they tend to generate forces, internal forces, when they're put in particular positions. And so when the curves are exactly opposite to one another and straight, they retain a lot of energy. And then if they move beyond that, they can suddenly move more than a few millimeters at one time. So it's not quite uncontrolled, but it's slightly unpredictable. But you can modify these tubes with a laser cutter, for example, here, and make it so it has a very smooth profile. The other things we've been working on is modifying these tubes, which, as I said, are shape memory alloys, but you can remove parts of the material to make them, to increase their curvature so that you can bend them into more acute angles, and also increase the strength by doing that. And this is a couple of examples of that. So I'm going to talk about models in a minute, but we actually got into the modeling area basically to test the robotics devices. And this is an example of that, of using this model to test a robotic system. This is going through the foramen of Monroe and doing a 3rd ventriculostomy. So that's not a system you need a robot for, but that's a way of, we can test these robotic devices on models first before moving to any animal testing. And then we've become part of a fairly large international consortium, I guess, that has these Da Vinci test kits. So these are older Da Vincis that have been repurposed and basically donated by Intuitive without their software and hardware controllers. But the group has developed our own hardware and software controllers, and we can use these as a test bed. so that you don't have to, build a new robot every time you want to test a different tool. You can just mount it on this DaVinci test kit, and it's a very standardized platform. So we've been using that a lot. And this is one where, if you've ever seen a DaVinci, this is what the standard DaVinci connection system looks like. There's 4 spools that are controlled, and then we can build and 3D print the rest of it fairly quickly, and we can prototype these fairly rapidly. And it's now a long time ago, but we actually won the surgical challenge at the Hamlin Robotic Symposium with such a system. So this is one, this is a concentric tube device on a DaVinci, and you can see that it does move pretty quickly and has a fairly large workspace, and is actually quite controllable. So this is what we think is a good test bed, and we'll give some other examples of that. And we actually, kind of unknown until this point, but we actually did win this, very proud of that. And we've actually won various elements of this competition a couple times since then. Of course, it was taken out last year by COVID. The whole thing was canceled. So we're hoping that it'll happen this year. And these are examples of some of the engineering students at the University of Toronto as part of their 4th year thesis working on different tools. So I mentioned that one of the big problems with interventricular surgery is having a bipolar that works. And I'm just going to show you very quickly. This was part of our one of our submissions to the surgical challenge. We mounted a robotic bipolar device on a DaVinci test kit and use it here on I think it's a Mango. And so so we think the bipolar is a very key part of this, and I'm just showing how we could use this bipolar to go around corners and coagulate blood vessels, and you can actually compress them first and then apply the cautery and then remove them. And we're looking at ways that we could actually also clean them. And this is another version on a DaVinci system. This is a slightly different configuration of the tubes, but this is doing surgery inside a red pepper using the DaVinci test kit with 2 2mm arms. So this sort of thing would be very difficult with a standard endoscopic system. So we're obviously exploring a variety of approaches, and I mentioned our collaboration with Pierre Dupont at Boston Children's, and the ultimate goal was to create something that would be totally MRI compatible. At this stage, we're actually building something that's not MRI compatible, just to make sure that we have all the issues ironed out, and we're about to start animal testing with this particular system. So as I mentioned, it's not just neurosurgery, and this is a tool that was developed by our ENT collaborators and graduate students in the lab to do endoscopic surgery inside the external canal. And another submission to the surgical challenge, as you can see, the Hamlin Medical Robotics Challenge. And just very quickly, this is the type of prototype that we can put together reasonably quickly, and this was actually a PhD thesis for one of our graduate students who's now actually over at Imperial College, where the Hamlin Robotics program is. And just an example of the type of, and this robotic system could obviously be used for other applications. So we've also been looking at some more novel instrument design. So this is a collaboration with one of the professors of mechanical engineering who's interested in micro robotics. And this is a magnetically control system. So these are grippers that have magnets on them, and you control them with external magnets. And just show here what these devices can do. So this is working inside the foramen of Monroe, and there's nothing controlling this but the external magnets, right? So it's going to pick up a P and then bring it back out. And this is where we see this technology potentially headed. This is an untethered robot. So this is actually something that you could theoretically inject. This is about 4 millimeters in size, and it's being controlled at the top here by external magnets, and it's going to come up here. It's a pair of scissors, and it's going to come up here and cut this piece of plastic in half. There you go. And this is another application for cleft palate repair. So this is the Da Vinci test kit, and this is one of our cleft palate simulators. And the standard Da Vinci instruments, which have been used on occasion in the adult airway, are too big for 8-month-old infants when this repair is typically done. So we're working on that as a new tool design. So on the left side, that's a standard 5 millimeter Da Vinci tool, and on the right is our 3 millimeter prototype. And there are no 3 millimeter Da Vinci tools that at the moment that are available. But we have mounted this on a Da Vinci test kit. So the Da Vinci system does not have feedback. One of the issues where some of the complications have arisen because you cannot tell what you're pressing on. And so we think feedback is important. It's very hard to do it mechanically just because of the design of the robotic systems. They tend to become a little unstable. And this is a bone conduction hearing feedback system that records the stress on the tip of the instrument, and it's fed back to the surgeon as with bone conduction headphones, so that it doesn't create a lot of noise. You can still hear everything that's going on, but you also do hear what the stress on the tip of the instruments is. And we're also looking at other applications, and so this is we have a College of Art just down the street from us, and one of the professors there has produced, he's a sculptor, has produced a fetal model of the pregnant abdomen and fetus for a variety of applications, and including simulation of myelomeningocele. So this happens to be a chicken breast, but this is a real 24-week size fetus. It's inside about a 24-week abdomen. And we've been using the Da Vinci to do the repair. So right now, many centers are moving to laparoscopic repair of myelomeningocele. It's a very lengthy operation, and they're using 3 millimeter tools. And so we're trying to develop tools for that application on our Da Vinci test kit. And so with the Da Vinci test kit, we can do this repair in about 11 minutes. So sort of thing we think in terms of fetal surgery might have a significant future. So I'm going to move on now to modeling, because that's also been a large part of what we've been involved in. And this is projects that are driven by the craniofacial surgeons, and their idea is to standardize craniofacial surgery. And so what they've done is taken a large volume of normal heads from CT scans that were done for other reasons in 8 to 12-month-old, and created this normal skull, and can scale it for the age between 8 and 12 months, and then design these templates that fit over the skull in the operating room. You can do it virtually, as I'll show you in a minute, but you can also, they're also brought to the operating room for the actual repair. So this is it virtually. So this is a patient with metopic synostosis, and for this particular patient, this is what their skull should look like when they're finished. And this is using that tool. This is what the result was, and this is the virtual template put over top of this. And this is how it's used in the operating room. This is before the skull's taken off. This is where the cuts are made, and we've optimized these cuts with another project. And then the bandeau is shaped to the template, and then the reconstruction's done. And these are, early results, but they've shown a better correction. But also what's really interesting with this technique is you can also tell if there's been any kind of relapse in terms of return of the deformity. And we're also working on a project to make this minimally, so most of us are doing minimally invasive strip craniectomies now with the younger children. And we're trying to expand that to a robotic system. This is an ultrasonic cutting tool that would work on a Da Vinci system. I'm showing it here. And again, that's another area that we've been working in. So just want to talk a little bit about what we're calling therapeutic imaging using focused ultrasound. And as I said, this is a body system. And so one of the first applications we did was for benign osteoid osteitis. And so this is, so we developed this in an animal model. It had been done in Europe on a number of patients, but not in North America. So we developed this in an animal model. We also have animal models of interventricular hemorrhage that I'll show you for going through the infant skull. So this is the first patient in North America that we treated with an osteoid osteoma. We've now treated a series of these patients, and we've developed it for another of related applications for osteoid osteomas in other locations, for metastatic bone lesions, for soft tissue lesions, particularly the one we're interested in is neuroblastoma, but also for peripheral nerve and also for tendons. For the interventricular hemorrhage model, we're doing this based on the ultrasound window of a neonatal skull. As I said, we've developed an animal model for this, and we can show that we can lyse the clots using particular focused ultrasound sequence in these animal models. And we also have some early results on longer term follow-up studies in terms of trying to decrease the incidence of hydrocephalus in these porcine models. And this is the concept in terms of how this would be used in a premature neonate. And this is the robotic system that could be adapted for that particular application, but also a number of others. And we've also been looking at using focused ultrasound, and other centers have started to look at this. And some adults have been treated, and actually Miami is one of the first, I think, John and Travis Tierney to treat a hypothalamic hamartoma with focused ultrasound. And this is, again, in an animal model using white matter ablation. And I'm not going to dwell on this too much longer, but you can show that we can ablate, obviously, fairly accurately white matter tracts. And these are pre and post DTI images. This is in a neonatal pig. And I mentioned, these are lesions in the brain, and this is peripheral nerve. So you could do neurotomies with focused ultrasound. And then we're also looking at liquid biopsies. So using low dose ultrasound, you can cause transient disruption of the blood-brain barrier for up to 4 hours. It appears to be almost completely reversible. You occasionally see some small hemorrhages. So we're working with a group at the University of Toronto that are developing various microbubbles and liposome encapsulated microbubbles. And we're developing a system to do liquid biopsies. So liquid biopsies now done through the CSF is under investigation. And we're looking at this to see if we can do this through the bloodstream. So using encapsulated liposomes, disrupting the blood-brain barrier with low-dose focused ultrasound. And our target model is for diffuse intrinsic pontine gliomas. So all these technologies have their shortcomings. The focused ultrasound is obviously, it's non-invasive. The concentration of ultrasound causes a lot of effects. I've talked about blood-brain barrier disruption at low intensity. A lot of times it's used for thermal ablation, so that's where it's used for essential tremor. But the ultrasound beam doesn't stop at the target site, it keeps going. And so injury to structures either in the path, such as the skin, or beyond, such as the skull base, are not insignificant. And if you're doing this anywhere else in the body, then movement's extremely important. And so this is a system to compensate for the motion of the diaphragm if you wanted to treat for something exact like a neuroblastoma. And we're also very interested in fetal applications. And so I mentioned in utero closure of myomeningeal, but we're also interested in non-invasive treatments. And so the placenta and the fetus are actually very good ultrasound targets, if you like, because they're in a water bath, and you could have a transducer held by the robotic system that we've developed to treat fetal abnormalities. And some of the target ones are sacrococcygeal teratomas and other masses that could be treated. Right now they're treated with percutaneous thermal ablation, and the same for separating the placenta for twin transfusion. And so we've just got a grant to pursue this with MR-guided focused ultrasound. And these are some of the tools that you need to design. So I'm just going to, as I said, I'm sort of giving you a tour of what we've been up to. And as I mentioned, we got into modeling more to design robots, but it became apparent pretty quickly that these also excellent educational tools. And so, we're not new to simulation training in neurosurgery. I mean, this is one of the University of Western Ontario grad students who's a neurosurgeon now in Kingston, did a survey on the usefulness of neuroendoscopy for training. And obviously there's a lot of enthusiasm for this. And this is the simulator, as I said, we initially designed for to test a robot, but a PhD student from the Netherlands really took this to over the top, and we've developed this now into a simulator that we use regularly. We've actually also brought this to different conferences, including the one in Cape Town, and it simulates a third ventriculostomy, which I will just show you here. So this is Gerben Bremer, he's the PhD student, and this is in the lab. This is one of the simulations, and this is what it looks like when you're inside the ventricle. It's the choroid plexus, that's the floor of the third ventricle. We use a blunt instrument to perforate the floor, and then we'll use a grasping forceps. This is what we do here in the operating room. We also use balloons, but can also, simulate complications such as bleeding. So we have simulators. I won't go over all of them, but we have simulators for third ventriculostomy, for choroid plexus coagulation, for tumor biopsy, for colloid cyst excision, and for craniosynostosis surgery. And we hold these courses at least annually. And as I said, we've taken them to other venues. And we also have a virtual reality simulator that I'll show you in a second. So we validated the third ventriculostomy model, and we validated it as a training tool. Where is simulation headed? I think it's very hard to predict. So this is virtual reality simulators developed by the National Research Council in Quebec. So we have the University of Toronto's purchased this instrument, and this is a simulator for a third ventriculostomy, and the graphics are amazing. And you can see the choroid plexus is beating in the breeze, and in a minute it'll show the third ventriculostomy. So that's the floor of the third ventricle. But it does have some haptic feedback, but it's, you know, I think it's fair to say it's still under development. Sorry. And the individual failed because they were going to go through the mammillary body, which, okay, and that's the therapeutic colostomy. So we've compared these two, and you know, there's advantages to both, and I think the graphics are better with the realism of the environment is better with the simulator, the virtual reality simulator, but using the tools and having absolute, you know, real haptic feedback was seen as better by the students when we compared them. And this is the colloid simulator. I won't go to, but this is the metopic synostosis simulator, and this is the sagittal synostosis simulator. You know, we 3D print these, and then we also have, you know, bleeding scenarios for these as well. And we're also using these to develop our endoscopic bone cutting robot. And you know, and we've validated these to some extent. We haven't shown that this actually improves someone's performance in the operating room, which is what you actually need to do with a simulator to show it's, I think, of enormous value. But anyways, we're on the road. And then one of the cardiac radiologists got very involved in 3D printing infant hearts with congenital malformation, and this has launched a whole cardiac training module that's now used all around the world. And 3D printing, I haven't said a lot about this, but 3D printing patients is something that we do quite frequently, and also for the cardiac surgeons. So I'm straying now beyond neurosurgery. This is a neonatal simulator for premature infants that was developed by one of the radiologists. And I'm showing this just because a little bit of the background. So this was designed by one of our intensive care physicians who unfortunately passed away last year unexpectedly. And he developed this for ARDS, which everybody knows about. And the idea is that he would create an iron lung that would go around the abdomen. And this would decrease the abdominal pressure and increase the perfusion in the lungs. And this is the kind of idea that, you know, he came up to the lab, he got talking to some of the students, they 3D printed this cage. It's controlled by an Arduino, which is a hobby computer that costs about $35. And we tested it on the students. And then in May, so he set up a clinical trial, which got stalled, you know, when he got ill. And then it was relaunched in the middle of the pandemic, and it actually went into clinical trials. And because it was at more than one center, we needed Health Canada approval. And this is right in the middle. And so we got Health Canada approval in one day to put this device into clinical trials. And we have not seen the results yet, but just a sort of very simple device, you know, got it to humans, and it's been tested. So I've showed some very complicated projects that have taken a very long time, and then it's some of the most clever and innovative ones that are simple that actually get launched the fastest. So I'm going to finish up there. So I hope I've given you a tour of what we've been up to over this last decade. I think some of the points I want to make is that I think this is a good way to drive innovation in medical technology. I love this collaborative ventures approach. I think having the mixture of engineering students and medical people mixed in together, working together in the lab is really creates a positive environment. There's a lot of interest in this amongst the physicians here in the hospital and beyond. And finally, you know, pediatrics often gets left behind with new technology. It's designed for adults. It's a much larger market. And the incidence of disease in pediatric patients is often much less. But we do need devices that are specific for them. And if we are able to design them and get them out to pediatric patients, they also would probably work in certain adult scenarios. So again, I just want to thank you very much for inviting me. It's been a great honor to give this lecture in memory of Sanjeev, and really appreciate the invitation. So thank you very much.
Thank you, Jim. That was really spectacular. I mean, the body of work and the amount of material you covered, any one of those topics would be a great hour lecture. We could fill the entire Grand Round schedule with your work. But I'm gonna take advantage of the first question. So, one of the real challenges, Jim, has always been depth perception when you do endoscopy. And I'm sure that's one of the things you guys have taken into consideration. Maybe you can answer that while other people fight for who can ask the next question. And then, of course, my next request is an Alan Levy story from when he was a resident. So I'll let you go. Thank you, Jim, for doing this.
Well, I could start by talking about Al's car, but I'm actually not going to go there when he was a resident. But no, he's sick of hearing about it. Yeah, so I mean, the system that we're developing at the moment with the Da Vinci test kit is, so the Da Vinci is a binocular system, and the image quality is unbelievable for anybody who has ever tried it. And you really do get the idea that you're immersed in the surgical environment. You really do get the feeling that you're immersed. But it's also 10 millimeters in diameter. So that's the scope. So, we're working on miniaturized scopes. And we looked at, and we do have a 3D binocular scope that's 3 millimeters. The image clarity is not the greatest. And the closer you get the lenses together, the harder it is to create a real 3D field. But that is very much part of what we are trying to do. There are, these chips on cameras that are chips on tips that seem to be getting better and better. And so as long as you can separate them enough, I think you will get reasonable binocular vision. And I do think it is a key component. I mean, if you talk to some of the adult skull-based surgeons, and you probably have some here, I don't know that they're all convinced that 3D view is that important, but I think it's certainly something that we want to get to.
So to clarify, that current one is two 10 millimeter scopes that give you binocular vision, or both?
No, so the Da Vinci is a singular scope, but it has two lenses, and it produces excellent binocular image, but it's 10 millimeters in diameter.
Wonderful, thank you.
I'll ask a question if that's okay. So obviously, as pediatric neurosurgeons, we're a very small market for a company like Da Vinci. I mean, urology has tons of procedures. Pediatric neurosurgery is a niche within neurosurgery. Have you faced any pushback from them of being interested in something that's such a small market? Or have they been a ready partner, and how have you dealt with that?
Yeah, no, I mean, the initial conversation, usually starts out, well, is this about heart disease, stroke, or diabetes? And, but I think that there has been success in niche markets. And, I do think that if we develop a system that'll work in a pediatric patient, I think you could also use it in adults. So that's what we have to certainly think about. We have not had great success in engaging companies, and most of them will want to see evidence of clinical efficacy before because that's where the risk is, and they're not really willing to assume those risks. So, I would say that the ROSA systems and the Neuromate, they're kind of niche market, right? And yet they've been pretty much embraced. So nothing like the Da Vinci, but I still think that there's I still think that these are viable propositions. And one of our PhD students spun off the cleft palate simulator, and that was recently acquired by by an NGO. So it can happen, but it's hard.
Thank you.
Hi, Jim. This is Jacques Morcos. I greatly enjoyed your presentation. I remember 20 years ago, we tried actually to collaborate from our lab with Donald Sutherland in Calgary when he was trying to, well, when he was working on his robot. But you're absolutely right. The haptics is a big problem, isn't it? I mean, that really limits what you can do. We're interested in, automating bypasses and so forth. Do you see this as a stumbling block in the future of replicating surgical skill, I guess?
Yeah, I mean, I think it's doable. I mean, there are other ways of providing haptic feedback than force sensors, but that's certainly a big part of it. I have a feeling that the evolution is kind of going to be like it is with self-driving cars. So now you have cars that are self-driving, but you have to have a driver there sitting with his hands practically on the wheel. And so I think that would likely be the initial stages. There are things that you can do with robots that you can't do with humans, and that's when you get down to sub-millimeter scales of movement and removing tremor, and you can also enforce boundaries that you cannot go beyond. So that's where I think it'll likely have the role. I mean, designing a robot to do a third ventriculostomy, I don't think is, because that actually works quite well. But designing one to remove a tumor, I think that is something that may have more traction. I mean, you have to be careful about underestimating surgeons' ingenuity and skill, right? That is extraordinarily hard to duplicate. But if you can facilitate it, and if you can enhance it, that's where I think probably the advantage is.
Agree. Thank you very much.
Other questions for Dr. Drake? All right, Jim, I got one for you. So it's time to buy a new microscope here at Children's. And my sense is that we're not going to be looking through the oculars of a microscope hovering over the patient any longer. What do you see in the future for how we do open microsurgery? Are we still going to use a microscope like the ones we've used for the last 50 years?
Yeah, I got to be careful here because I think I'm too old. So we've tried the overhead cameras, with the display on the screen pretty diligently, and I had trouble relating to it. And by the way, I'm not making a pitch for anybody here, but the new Zeiss microscope appears to do both, and it's partly robotic. And so I'm not sure the microscope is over, but I think probably what this is going to look like is that you're going to be wearing glasses that, or you're going to have projection. Whatever you're looking at is going to overlay all kinds of information that you really need in order to do the operation safely. And there'll be all kinds of feedback in terms of what's actually happening. And if you are doing this operation remotely with the patient in an MRI scanner, you're going to be looking at a computer screen, not at a microscope. So those are some of the ways I think this might change. But I'd be interested in your experience with I forget the name of them now, but you know what I mean. The cameras that sit over top of the patient, and you look at the 3D display. So what's your experience been there?
Those things they call exoscopes, I have no experience with, but it just seems to me that if there's something begging to be improved upon, it's the cumbersome machine with the giant drape that hangs over the patient's head. Yeah. And I'm sure your team will get to it. It's just a matter of time.
Okay.
Well, if we can't extract an N11 story from you, we're gonna thank you really for this spectacular talk. For anybody interested, Dr. Drake's going to give a talk for the pediatric grand rounds at Nicholas Children's tomorrow morning at 8 on hydrocephalus. It's a topic that Jim has written extensively about and is one of the world's authorities on. So we're really looking forward to that hydrocephalus talk. And I know the residents are looking forward to going over cases with you and sharing lunch virtually. So Jim, thank you so much for doing this and honoring us and the memory of Sanjeev.
Well, thank you very much, John. It's been an absolute honor and pleasure. And just want to finish by saying how much we all miss Sanjeev. Okay, bye.
Thank you. We're looking forward to sharing a glass of wine tonight. We'll see you in June tonight.
Bye.
Bye. Thank you.